Well, I'll go ahead and just do a welcome. Thank you for being here. I appreciate you sharing your lunch hour with us. Um, for those of you here, hopefully you found the snacks in the hallway. And I'm glad that for my friends in Asheville, you guys hopefully have found your snacks. And then for those of you online, I hope that you're enjoying a delicious lunch of your own choosing. So I do have an important slide up. If you are someone who is wanting to receive credit as a learner for campus life experience, so please go to the link or scan the QR code because this will get you some of whatever that magical credit is. I'm not exactly sure what it is, but I hear it's highly coveted and desired. So my name is Stephanie Kaiser, and I'm going to be kicking us off today. And I serve as project lead on the project that we're going to be chatting with you about. And we are delighted to have been invited by Carolina Engagement Week to come and share some of this work with you. And as pharmacists, to kind of give you a glimpse into things that pharmacists are interested in and collaborating in across the state. So I'm going to let one more click the scan, and I can always pop that back up too. So here are my partners. They're here in the room with me, and we're kind of going to do a handoff. I'm going to kick us off with a little background and tee this up for conversation. But Lori Armistead is here, and she works with UNC Asheville School of Pharmacy. She holds a variety of hats at the university here, and she maybe will tell you a little more about that. For me, she has been an incredible project manager. So could not have accomplished what we've accomplished without her, really, truly. She is the analysis to my excited brain. So I would overlook lots of things if it weren't for Lori. And then Emily Owens is our community partner, and highlighting her with a big shout out because she's also a UNC Asheville School of Pharmacy alum. She is from Old Fort, North Carolina. Anybody in this room know where Old Fort is? Some of you have to pass it to go to Asheville. Okay, it's at the bottom. It used to be a fort. There used to be a train, all kinds of great history and stories. There's a geyser and a waterfall. Okay, we got it. So if you didn't know there's a geyser there, there is. Emily provides incredible care in the region of Western North Carolina in a federally qualified health clinic environment. She's going to share a lot more about that. And then myself, I'm Stephanie Kaiser. I'm Director of Rural Health with UNC Asheville School of Pharmacy. Also work with MAHEC or UNC Health Sciences at MAHEC as Director of our Interprofessional Education and Practice. I've lived and worked in Western North Carolina for 30 years, but I hail from Eastern North Carolina, near a crossroads known as Spivey's Corner. So I've got a lot of rural in my background. So here's the background. Here's the project. Lots of words. I'm just going to put it up because it is the project and what we focused on. But it came from my having lived and worked in Western North Carolina for as many years as I have, and knowing that we really don't have this comprehensive understanding of how is pharmacy care, how are pharmacy services being delivered to some of our patient populations that might experience vulnerability. That's a big word, but patients that just have challenges or barriers for some reason. Additionally, folks that might be on complex medication regimens, so taking lots and lots of meds. I always call those the not the little brown bag, but the giant grocery bag full of meds when they come to see you. And then they're dealing with chronic health conditions that for a lot of reasons, maybe they're not able to manage those as well as they would like, and they're not achieving the outcomes that we all like our patients to have, right? We want their diabetes managed. We want their blood pressure to be managed. We want their cholesterol to be managed. So we set out to understand what is happening in our region as it pertains to some of our more under and uninsured patient populations. So we focused on federally qualified health centers, and I'll tell you a little bit more about those. But this is our needs assessment team, and I think it's important to share the puzzle pieces of this. So, of course, UNC Asheville School of Pharmacy, primarily coming from our Asheville campus because we are based and anchored in Western North Carolina. The Alliance of Integrated Medication Management. So for pharmacy people, I would say check this organization out. They are doing a lot in the world of how do we advance pharmacy practice, how do we elevate the message of pharmacy practice, but they're also very good at analysis and data gathering and convening and collaborating. And they're known at a national level in the US. So expertise in med management and oversight and consensus building. And then UNC Health Sciences at MAHEC, because one of the things we have as an asset in our region is through UNC Health Sciences at MAHEC, they're very connected to the FQHC clinics across the region. We also call them rural teaching practices. And the reason we call them that is because they take a lot of learners, and not just pharmacy learners, med school learners, pharmacy, nutrition, social work, you name it, they have learners rotating through their clinical practice environments. And you're going to hear from one of the pharmacists that practices in one of those rural teaching practices today. And then we could not have done this at all without funding from the Dogwood Trust. Again, funding, grant support, and some guidance, because they're very, very integrated across the region. They've told me things about things happening in communities that I didn't know. I was like, oh, I should connect with that person. So these are kind of the 4 pillars. There's lots of other people that have been involved in lots of different ways, but this has kind of been our anchor team. And then these are our regional partners. And I checked to make sure. I think the gray shows on the map on this side. Sorry, on the back here, it looks like part of Western North Carolina. It disappears, but it's still there. So this is a map of the 20-ish, 20 plus, 18, 19 counties of Western North Carolina that we are targeting for the work. And the clinics on the left-hand side, so Appalachian Mountain is a federally qualified health center with 6 clinics that serves 7 counties. And then Blue Ridge Health, not to be confused with Blue Ridge Hospital in Morganton or Blue Ridge Hospital in Spruce Pine, but Blue Ridge Health Centers, because we like the Blue Ridge Mountains and using that. 14 clinics serving 8 counties. And some of these are clinics that are dental clinics. Some of these are pediatric neurology. There's some multidisciplinary, some specialty clinics in there. And then we have Mountain Community Health Partnership, MCHP, that has 4 clinics serving 3 counties. You're going to learn more about that. And then the Foothills Medical Associates is affiliated with St. Luke's Hospital, serving Polk County. So 1 clinic, 1 county. What's really interesting about all of these that we are learning is they all have some elements of team-based care. They all have some elements of incorporating pharmacy into that care, but none of them look the same. And so for me, that's the reason we're doing the needs assessment. I want to learn about the bright spots in these clinics. I want to learn about their wish list for these clinics and what is it that we might help influence and encourage to continue to grow the footprint there. And then the dots are basically, that's where all the clinics are. So you can see, in some of these counties, you see just one little dot. Now, what I also want you to imagine about some of these counties is mountain geography. So some of these clinics, if I'm standing in Asheville and I go, oh, look at that little dot's right over there. That's just 45 miles away. That might be an hour and 50 minutes for me to get there. Okay. So I want you to understand that it's challenged by geography. So think about folks that they like to live remotely sometimes. The clinics might be in the nice epicenter, but you could have patients really traveling to get to you when you're at your clinic base. It's not like living in Eastern North Carolina where 45 miles is like 45 minutes, like straight. It just doesn't work that way. All right, this is a very busy slide. And I'm going to talk towards the pictures, okay? So I was always a visual, I always like to look at the pictures, but you can we'll walk through this. So here are the big 6 topics of interest that we're looking at. So we want to understand the size and the scope of the patient populations that we feel could benefit from advancing maybe pharmacy practice, medication needs management, medication access. We want to look at the barriers, what's getting in the way of making that happen, not only for patients, but for the care providers. We want to think about what is the mix of services that could create success for us and help people achieve their desired health status. And I say their desired health status because they don't always want the same thing we want. But the type and the configuration of a system that could help provide those services, the readiness of these clinics, these counties, and these communities to engage in this work. And then finally, how much is it going to cost? That matters a lot, right? Because these clinics, I could just say, here you go. Here's the golden platter of services that you should offer. Well, where's the money going to come from to assure that can happen? So we have to understand how that might need to have an incremental approach, but how might we also push to transform practice? So the pictures are we're getting information from the practices and lots of data repositories. You would be amazed at the amount of data that's out there about federally qualified health clinics. If you ever want to learn more about that, take a look. It's actually federally qualified health centers. I keep saying clinics, but they're centers. We are working with providers. So anyone who is a prescriber, and that could be a CPP, clinical pharmacist practitioner, which if you don't know that term, Emily's going to tell you about it. We're working with patients. So patient voices are incredibly powerful in this work for us. And then we are also talking to pharmacists, and that's pharmacists that work within the FQHC, but pharmacists that also are working in the nearby small independent and community pharmacies. So really trying to get a collective picture. And then finally, community stakeholders, because you can't accomplish all that you need with just clinical care. You need food resources, you need housing resources, you need transportation resources. So what does that look like in the communities we're working with? So I'm going to transition to Lori, but before I do that, I want to put this phrase up. This I've had spoken to me many times over the course of 30 years of practice, and it's always been in the space of when we were doing community engagement. And we often, as healthcare providers, lean into the space and say, we have all this knowledge and we have all the solutions and we know how to make this problem go away. But here's what's important. If the individuals and the communities and the people you're collaborating with do not see themselves in the work, and they are not part of the work, and you are not listening, all your knowledge will be for naught. So someone much smarter than me came up with nothing about us without us is for us. So that's a driver for me in decision making on this work. And I'm going to hand it to Lori Armistead, who's going to tell you about the fun stuff of logistics. So here you go. Lori.
Thanks. I don't know if fun is the correct word, but it's very important to understand how to make things work. So quick introduction. My name is Lori Armistead. I am a pharmacist. I did my training here at UNC School of Pharmacy a little later in life, coming to the profession. But I currently work at the school as a senior research associate and project manager for a variety of different research projects, this being one of them. And this is a very fascinating project. I've really enjoyed it, mainly because of all the wonderful people from Western North Carolina that I've been able to meet, as well as our team as a whole. So it's a great team. I'm going to dive into the logistics of this project, try to be quick, but I just want to give high-level, step-by-step sort of how we're approaching things, because I think there's some very important lessons we can learn of how to engage with these types of communities. So first of all, I just want to highlight sort of the 6 steps that we have been taking in this project to try to accomplish our goals. The first step, 1A, prepare needs assessment questions. We did a lot of background research, lit review, because we're good academics, and looking at other needs assessments and trying to decide what exactly do we want to ask of these people in these communities to find out the information that's most important to us. And based upon all this background review, we then developed survey questions and interview guides for the different populations that we'll be engaging with. At about the same time, we were also identifying the target FQHCs and other clinics that we wanted to approach to engage with this project, the 11 counties that Stephanie highlighted. And most importantly, that we found out sort of a few months in, the importance of this is that we assembled a pharmacist advisory committee. This is a group of 5 pharmacists, Emily being one of them. Each of them work within the FQHCs, and they've been very integral in helping us become engaged with these organizations, primarily because they know them. They know the providers in the clinics. They know the, I guess atmosphere and how the best way to work with the folks within the clinics. And they've given us a lot of advice of how to ask certain questions, how to approach the different people for engagement. Because as Stephanie said, each of these organizations are very different, have very different cultures. And so these insiders, as it were, very helpful for us in building our relationships and engaging them. Once were able to get some FQHCs on board, we then began to specifically target individual providers, pharmacists, staff members, and patients in these clinics. And once we got them on board, we conducted the surveys and interviews. So steps 2A and 2B were sort of done in a cyclical, phased manner because some people took a little longer to get on board than others. Also, as we interviewed folks, certain providers, we learned about other folks within the clinics that could provide very interesting insights, such as medication assistance coordinators, community health workers, and nutritionists. In one case, there was a community paramedic who runs a paramedicine program, and they provided tremendous insight on the needs of patients in their communities, even more so, or at least different from the provider's perspective. So it was very helpful to talk with them. So, we have conducted at this point a little over 40 interviews. We hopefully get a few more patients, but as we're wrapping up phase 2, we're moving on to phase 3. Before I move on, I do want to highlight that steps 1A through 2B, even though they look pretty logical and straightforward, it took us over a year to get all of that done. And we met weekly as a team, and we've been very focused and we haven't let time slip away. We've been very focused on trying to get the work done. It just takes time, largely because a lot of the relationship building and getting things, communications across well. As I said, we're moving into phase 3 or step 3 now, where we're taking everything we've gathered through the surveys and interviews, trying to analyze it all. It's going to take a while to do that. AIM's going to be very helpful with us as we do that to identify the key findings that we're interested in. As Stephanie said, we want to identify the bright spots in each of these communities, what the clinics are doing well, what community services currently exist. We also want to identify the gaps. What are the needs that these communities still have? Once we extrapolate all these findings, we're going to pull together folks in the community, some of the providers and pharmacists and stuff that we've already talked to, as well as some additional community folks. We've thrown around ideas such as folks at the community or county health departments, as well as like food banks, et cetera, and try to get their input on moving us to step 5 to prioritize what are the top most needs in each community. How are we going to prioritize these? Because we would love to address everything, but we can't. So we need to decide, first of all, what is most pressing, what are the greatest needs, but also based upon the bright spots that we've discovered, what are some of the most impactful innovations we could implement in these communities to address those needs. Eventually, we'll present to stakeholders, the FQHCs themselves, as well as Dogwood Trust, to try to figure out what are our next steps and how we're going to fund those innovations. So the patients ultimately are our topmost focus. We're talking to providers and those that work with patients to understand the patient needs, but most importantly, we've been talking with patients themselves. Now we have focused on adult patients in these communities that are first and foremost uninsured or underinsured. That's why we focused on the FQHCs. FQHCs are designed largely to help these types of folks. We're also interested in patients who are at high risk for poor health outcomes, either by clinical measures such as A1C or blood pressure, healthcare utilization. If they're on a ton of meds or have a ton of chronic conditions, we wanted to talk with them because they're at higher risk for poor health outcomes. We're also very interested in understanding the social determinants of health that these patients face every day that impact their ability to access their medications, afford their medications, take their medications as prescribed, manage their chronic conditions well. Social determinants of health, Stephanie mentioned a few, limited access to reliable transportation, limited access to housing. Homelessness is a much larger problem in rural America than I realized. And they don't have many solutions, in some ways, fewer solutions in urban areas. Cultural or language barriers. There are pockets of migrant populations throughout Western North Carolina. And there's also just folks who just struggle across the board with economic struggles, low pay or not enough income to meet their needs. So we want to understand what those influences are and how they impact their health and medication use. And then finally, we want to talk to patients who are engaged at least somewhat with their clinic and exhibit some readiness or motivation to change or improve their health. Basically, we want to talk to folks who have need and who are, least willing to look for the support that they need, engage with community and clinic-based resources. So lessons we've learned along the way. First of all, as we've mentioned a couple of times, this engagement of the pharmacist advisory group has been very, very important. Again, the relationships that they have with the clinics and the relationships we have with them, we can leverage all those relationships. Because if we just tried to reach out to these clinics kind of as a cold call, we wouldn't have gotten anywhere. So it's important to understand the importance of relationships and relationship building in this project. Stephanie's been great with that. I think she knows everybody, so that's very helpful. Secondly, feeling overwhelmed is a significant theme across the entire region. Patients are overwhelmed by the daily challenges that they face. Providers are overwhelmed because of their daily workloads and also just their desire to really help these people who are in great need. And so therefore, we've learned to approach the clinics one step at a time. This project, there's a lot we're asking of the providers, survey, interview, refer patients to us, have a follow-up focus group. A lot of that is, as a whole, is very overwhelming. So we've learned to approach it one step at a time. Just ask first, hey, can you complete this 10, 15-minute survey? Give us your input. If they engage with us with the survey, then we can ask them for a follow-up interview and on. And then finally, kind of relatedly, polite persistence is a term we use. Persistence, because you don't often, have much success if you ask someone once. A couple reminders, a follow-up email, a week or two after the first one, maybe two follow-up emails is helpful for people who mean to complete the survey or mean to set up an interview but forget, we're busy. But politeness is very important to understand that they are very busy, to be able to work with their schedule, but also being willing to accept no or a no response because they just may not be interested. And then again, leveraging these relationships we have. A couple of times we've reached out to Emily and she's verbally talked to her providers and say, hey, you want to participate? And maybe they do, maybe they don't, but sometimes that personal touch helps again. But we're polite, we're not obnoxious. We don't spam them with emails and we don't bug them all the time. If they just don't seem interested, we let it go. A couple more lessons we've learned: to be very flexible. Some patients we found they're very willing to connect over Zoom, particularly if they're comfortable with the technology and they have internet access. Not all of them do. They seem to like that perceived distance. They can turn off the camera, they're in their home, and it's a safe conversation. Other folks, however, really enjoy that person-to-person meeting. So Stephanie and I have been flexible and been able to travel different parts of the state to meet with patients. In fact, 2 weeks ago, we were camping out in Emily's clinic, sat there for 2 days, and then whenever there was a patient who was willing to talk with us, we went and had an interview with them. Some patients weren't interested. They don't want to talk to strangers, but others were. And one guy in particular could have talked to me all day. I think it was fun. Yeah. And then, as we mentioned, there are some community resources. And so it's not just developing the resources in the community, to be able to connect patients to the resources. A lot of them weren't even aware of what's there, that they could call on a transportation service if they needed it. And then finally, the last point, Stephanie and I have been very happy and pleased and excited to meet the different providers, pharmacists, the clinic staff in these communities. They live and work in these communities. They're incredible advocates for their patients. And I would say that they're the top number one resource that these patients have. Maybe they don't see them as such, but they really, really are. It's the greatest resource that I think the patients have for managing their health and meeting their medication and chronic condition needs. And with that, I'm going to turn it over to one of those wonderful providers, Dr. Emily Owens, who is also alum of the School of Pharmacy and a rural scholar, I believe. So here you go. And she's from, I'll go ahead and switch. She's from the Mountain Community Health Partnership in Bakersfield, North Carolina. Thanks.
Thank you so much, Lori. Thank you guys so much for joining us today. Like Stephanie and Lori alluded to, my name's Emily Owens, and I'm a clinical pharmacist practicing in Western North Carolina. So Stephanie already let you all know that I'm from a very huge town in Western North Carolina called Old Fort. It's about 30-40 minutes outside of Asheville. You can see in the lower left-hand corner our bustling downtown area. Literally, that's it. If you blink, you'll miss it. And we have a whopping population of about 800 in our town. So very much a rural community. Everybody knows everybody, and everyone who lives there is really passionate about their town. I was a UNC alum, as Stephanie also alluded to. I was a member of the Asheville campus and also a rural health scholar. So I worked very closely alongside Stephanie, both as a mentor, still even now, and also as a professor when I was at the Asheville campus, really helping me to learn more about what barriers patients face who live in rural communities. I graduated in 2018. After graduation, I moved with my spouse to Seattle, Washington, which was a very large shift. We wanted to do something new and exciting, and that was definitely it. I practiced there at a federally qualified health center, so much different than my rural background, more of an urban area. And so that really helped me to learn a lot more about different types of patient populations. We lived there for about a year and a half and we had fun, but city living was not for us. So we wanted to move back closer to Western North Carolina. We ended up in Johnson City, Tennessee. I practiced there for a little over a year at a primary care clinic. And then in 2021, I was able to move back to Western North Carolina, and I'm practicing now in communities where I grew up, which has been wonderful. You can see in the photo in the lower right-hand corner, this is a picture of some of the homes in Bakersville, North Carolina, which is where I practice now, which is just one county over from McDowell, where I grew up. And surprisingly, that town is even smaller than Old Fort. So I know a lot of folks in the room are familiar with what a CPP is, but I wanted to just highlight that for anyone who is not. So my practice is a little bit different than your traditional pharmacist setting, maybe a Walgreens or CVS or what you may think of when you think of the word pharmacist. So I'm a clinical pharmacist practitioner. And basically what that means is I've had additional training and also some extra credentials to be able to practice alongside providers in a clinic setting. So almost anything that a provider can do, I'm able to do as well, practicing with them. So I prescribe medications, I monitor patients who are on high-risk medications, order labs, have office visits with patients, all of those things. So providers will refer patients to my schedule for a variety of different reasons. You can imagine working where I work, a lot of patients are not able to travel to go see a specialist. Maybe they're not able to afford to go see an endocrinologist. So the pharmacists serve in a lot of those roles. Some reasons why patients may be referred to my schedule is for more advanced diabetes management. So maybe providers are needing help really adjusting patients' insulin. Maybe patients want to learn more about being put on an insulin pump or various types of technologies for diabetes. So I'll see patients for that. Providers will refer to my practice for hepatitis C management. So once patients test positive for Hep C, they're referred to the pharmacist clinic. We work on access to those really expensive medications and monitoring the patients throughout their treatment. And I may just get a referral just for a patient. Maybe they're on 30-something medications, and we call that polypharmacy. And maybe the providers really want to help that patient maximize their medication regimen. Maybe there are some things that they're on that maybe they don't need to be. Maybe there are some ways that we can work to get those patients on a pill pack or make it easier for them. And then various other reasons why patients would be referred to me, but those are some of the more common. So Stephanie mentioned my practice already a little bit, but I wanted to dive in a little bit more because I'm a little bit biased, but I feel like it's one of the most amazing places to work. So I practice at Mountain Community Health Partnership. We have clinics mostly across Mitchell and Yancey County. And so Stephanie showed you a little bit about where that is, but here's a reminder. Those top two counties kind of in the very mountainous region of Western North Carolina. And we are a federally qualified health center. We've been bouncing that term around a lot. And the way I think about it is we receive additional funding and grants and various services to be able to serve and take care of more at-risk and underserved patient populations. And so no patient is turned away from our clinic, whether they're able to pay for those services or not. So if patients come to us and they do not have insurance, we still see them based off of what's called a sliding fee model. So they bring in whatever income they have, which is sometimes none, And we tell them, you may pay $20 for an office visit and this for a medication and so on and so forth. So we try to take care of everyone, no matter if they have insurance or not. Also, being an FQHC, it's recommended that we provide a large range of services. So it's really incredible all that we're able to offer in these settings. And just our really small clinics, we offer not only primary care services, we also have behavioral health providers that are embedded in each one of our clinics. So really focusing on the mental health needs of the patients in these communities. We also have a dentist office. So if patients don't have dental insurance or they need to have some type of service there, they're able to have that. We have a nutritionist on staff. We offer prenatal care, pediatric care. We have various school-based health programs, of course, pharmacists, and the list goes on. So it's really a lot that we're able to offer these patients. So we talked a little bit already about some of the patient criteria for this needs assessment. But this is kind of my list and what I feel like I see on a daily basis working in practice with these folks. I think pretty much all of my patients have at least one of these, if not multiple of them. So I wanted to go through just kind of give you a little bit of an example of the types of patients that we're looking at for this project. So some really common social determinants of health that my patients commonly have, of course, limited income. Talked about that a little bit already. This general overall lack of trust in the healthcare system. So maybe they heard from their mom's, brother's, cousin's, uncle that someone went into the hospital and they never came out. So they're never going to the doctor, right? I have patients who come in frequently and it's been 10 years since they've been to see a doctor. And the same goes for starting a medication. Well, I heard such and such started that and it killed their kidney, so I'm never taking that. So it's really a lot of education with those patients. We discussed already, we have some language barriers within our clinics, and we have resources for those patients, but that's still lacking in some regard. A lot of poor health literacy, unstable housing and homelessness, which I also didn't realize was as common in rural communities as it is. Lots of transportation limitations. So we do offer, if patients are able, a lot of telehealth. A lot of food insecurity. Sometimes patients don't know where their next meal is going to come from. And of course, as you can imagine, living in the mountains, limited access to technology, whether that be internet or phone services. So not only the financial strains of having that, but also living on the side of the mountain and not being able to have service. And then some common medication barriers that a lot of these patients face as well. So they may have multiple uncontrolled chronic conditions, a lot of poor medication adherence. So maybe they don't take their medications as prescribed, whether that be they don't understand them or maybe they're not able to afford all of them. Really complex medication regimens. So you can imagine kind of jumping around from doctor to doctor if you haven't been to see one in a while. And then also having lots of uncontrolled chronic conditions, you're going to end up with a really complex regimen. We also have quite a bit of unstable behavioral health diagnoses. And in some regards, this does include substance use disorder, frequent hospital readmissions, as well as something that we see commonly, non-compliance with provider visits. So being a federally qualified health center, we do unfortunately have a lot of no-shows. And we have policies for that to encourage patients to come in, but ultimately we're not going to turn someone away if they need care. And then as we've also alluded to throughout the presentation, uninsured or underinsured patients. So underinsured being maybe they have insurance, but it doesn't necessarily cover all the services that they need for those really complex chronic conditions. So diving into that just a little bit deeper, I wanted to give you all a specific patient example. So this is a clinical pharmacist patient and also a patient who has participated in our needs assessment. And of course, for patient privacy, the name has been changed. So we think this is Martha. She's a 70-year-old female. She comes to office visits at our clinic once a month for substance use disorder. She utilizes our primary care services, our behavioral health services, and she also meets with the clinical pharmacist regularly. She has mobility limitations since a below-knee amputation, and she uses a wheelchair. She has a very complex medical history. Besides just opioid dependence, she also has diabetes, arthritis, kidney disease, depression, high blood pressure, and high cholesterol, just to name a few. She's on many medications, as you can imagine, including insulin to treat her complex history. Access to her medications is a barrier, not only because of her mobility issues, she's also currently homeless and she has limited income for that reason. Because of the overwhelming burden of her social situation, food insecurity, taking her medications as prescribed and coming to office visits regularly is a huge challenge for her as well. So this is just one example of the patients that we're trying to learn more about through this needs assessment. So with that being said, you can see already why this work probably matters to me, working with these patients on a daily basis and caring about their lives and seeing them as frequently as we do. But a little bit more into that, I feel like this work is really going to help us gain a deeper understanding of the challenges that these patients face. So seeing them as frequently as I do, we understand that, but actually being able to hear that more from the patient side brings an additional value, I feel like, because patients are actually sitting down with Lori and Stephanie and actually talking about that more. So when they're coming in, we're talking about their blood sugars and their blood pressure and different things, but I may not always ask them every single time they come in, were you able to have a meal today? Were you able to afford your medications last week? And those types of things. So I feel like as both a pharmacist and a provider in this community, this work is going to open up so much more to really help us understand those challenges. And not only for providers, but also for community leaders. So what else can we do within the community to really help these patients? Kind of leading into that, I feel like and hope that this work will also open up more opportunities for additional resources within the community, different tools that we can use and help us learn more about maybe some different workflows that we can incorporate in to help these patients. Maybe this may open up some additional funding opportunities, some additional support to be able to take care of them. I feel personally that it's also opened up some extra partnerships for me personally with other pharmacists within the community, and have been able to reach out to those folks and learn more about how they're helping patients, and we can share how we're helping patients. So sometimes being in these counties where Stephanie showed earlier, just the one little dot, you feel like you're on an island. And so being able to know, 2 counties over, there are other people who are also trying to do this work, and they may have done it for longer than me, or maybe they're just starting to do it. So how can we communicate and gain connection? So the pharmacist advisory group has really been helpful for that. And then ultimately, at the end of the day, this work matters so much because I feel like it's going to improve the lives of my patients. And not only my patients, but patients all across Western North Carolina who are struggling with some of these things on a daily basis. And that is just no words to explain how important that is and how much that matters. So thank you all so much. I'll pass it back off to Stephanie.
I thought I'd just get up and moderate a little bit. So don't you all want to go on rotation with Dr. Owens and get to do the things she does? Okay, so just checking in because I know there's some pharmacy students here and there. Yeah, I mean, she is really doing things we talk about a lot in our pharmacy training program. But the thing she also emphasized is how important it is for the community pharmacists that are also in her community. So it's really, I think, helping us see this broad contribution, that it isn't just, there's not just one puzzle piece that can solve issues. So I think we should applaud for Emily Owens because she's amazing. That's why we're doing this work. But I thought I wanted to ask some questions. And so first thing, How many of you heard something that you kind of surprised you today about doing a needs assessment? Maybe it didn't surprise you. Maybe it was just like, huh, that's interesting. Okay, it's okay. You can't leave unless you learn something. So I'll keep talking until you raise your hand and you say you learned something, and then you can leave the room. Okay. What questions are coming up for you all? So we've got Asheville that can push to talk. We've got, I think it's about 6 folks on the Zoom, and we've got folks here. Any questions or just comments? They don't have to be questions. They can be comments. Yes, ma'am. So the question is a great one. Does the pharmacy provide specialty medications, and particularly a question about HIV medications? So are you doing PrEP in your clinic? I thought you were. Yeah. So yes. So I think that's some of the thing we're also seeing, maybe not consistently across all the clinics, but to your point, why not? Like why, if we have the ability in one clinic to leverage a clinical pharmacist and or the community pharmacist, how do we further our access of some of these really highly needed medications? So that's a great question. You want to add to that?
Yeah, I can. Yeah, so we are doing a lot of specialty medications. Sorry, no one can see me. Okay. Now I'm seen. And so one way that we work with that specifically on the clinical side is working a lot with our pharmacist partners within the area. So if patients have insurance, we may reach out to those specialty pharmacies and help with ordering those medications. We may have those medications shipped to our clinic and actually sit down with folks and go through that. We may have them shipped to their home. We'll help with some of the labs throughout that process as well. If patients do not have insurance, we are utilized in that instance too, because there are something called patient assistance programs that you can apply for through the drug manufacturers. So we'll sit down with patients, fill out that application, and have them be able to access those medications for free, and also ship that to the clinic or to their home, and help them throughout that process, because those programs require an update every year for those applications. Yeah, good question.
And I just want to say, having been a community pharmacist at a different points along the way, I've held like 25 pharmacy jobs in my career, but one was I worked in a community pharmacy that was tied to our hospital. This has been 25 years ago. And I had patients that traveled to the pharmacy I worked in Asheville, traveled 2 hours to come get their HIV medications. And so to now hear you have a resource in your community, is incredible. I just remember, I know Mr. Jones is coming today because it's his trip to Asheville. So it's great that you guys are doing that. Thank you. Other questions, comments? Yes, ma'am.
Of course. So my question is kind of going with that idea of community pharmacies, and if there's potential for collaboration between some of these clinics to help maybe provide better access to clinical services within pharmacy or community pharmacies that may be a little bit more accessible. Because I remember on the map, there's only like maybe one clinic for a whole county, but there's obviously plenty of community pharmacies. Is that a thought process?
Yes. I'm glad you're bringing that up, because some of the voices that are kind of hidden in this work at the moment, but are there for sure. Actually, I'm going to advance a slide just because I know you've got to do a little survey. I want a survey to be done. We have interviewed actually a lot of community pharmacists, and they're usually community independent pharmacy owners. And we are blown away by how much service they're offering in the communities they're in. I can remember one, I love it. He's very colorful on how he talks, but he's like, well, if my patient calls and they hadn't been able to get out of the house to get groceries, who else is going to take them a chicken sandwich? My delivery driver did it. That's just how he talked about caring for patients in his community. He's like, well, I run a cafe next door. I'm going to take them a chicken sandwich. The healthcare system doesn't pay him to take them a chicken sandwich. I mean, that's part of our challenge as well, is how do we elevate that powerful resource in communities, and how do we connect it to the clinic work that's happening? So for me, that's why we're doing this needs assessment, is to fully shine a light on the hidden contribution of some of these small business owners in these communities, and how they're partnering with the clinics, and how much advocacy these providers in the clinics and the pharmacies and in the local communities really have, and how passionate they are about the people they serve. So I wanted to think about like wrapping us up just a little early, but I wanted to see if there's maybe one last comment or question.
I had a question.
Yes, hey, Zach. Sure, go ahead.
Hey, First Kaiser. So for Dr. Owens, what has been like the general attitude or like reaction that you've maybe experienced when you have to sign people up for patient assistance programs or copay cards? Is there still like a stereotype, like, oh, I don't need that, or like, I'm not that type of patient? What has been your experience with that?
Yeah, that's a great question. I think it depends on the patient and kind of what some of their experiences have been and a little bit more about their background. And I think it's taught me a lot too about how to frame that too. You know, if I sit down with someone, maybe they've worked all their life and they have insurance, and I say, you know, oh, we'll be able to get this medication for free, but I need you to tell me all this information about your income, then they're going to immediately throw up a red flag, right? But if I sit down with them and I frame it in a way of, you know, this medication is going to help you in X, Y, and Z ways. Unfortunately, it's not covered on your insurance, or at this point in the year, if you have Medicare, you're going to fall into your coverage gap. We have a way that we can get it through the drug manufacturer for you for free. And then we'll go off of that. And then I'll say, usually we have to send some sort of income requirement with that. Usually these programs are really lenient. A lot of people think that they may not qualify, but usually they do. I have a lot of other patients who are in on this as well. So a lot of it is just how you frame it and really making sure the patients don't feel like, you know, they're getting a handout or something like that. So a lot of it too is also your relationship with that patient. So they know you and they know how you've taken care of them over the years. That can be helpful as well. A good question.
Okay, thank you.
Well, again, thank you all for your participation today. And I'll have my colleagues stand up and do one more round of applause, because I'm just telling you, I couldn't do any of this without them. I really hope that as we get into the fall and we wrap up this grant, that we're coming back next year and sharing with you, here's all the money we asked for to make all this happen. So, you know, I'm already in my head trying to generate a wish list, and I'm stopping because I'm trying to go back to what I said before. I can start thinking about all the solutions and ideas that I have, and I'm ready to go because I love bright, shiny stuff. Let's make it happen. But I've got to stick with the rigor of making sure that what we suggest and what we pursue is really what our community partners want, what they can support, and what they can see themselves in. So thank you guys so much. It's been great having you. Thanks to my Asheville friends and folks that are online, and y'all, everybody have a great day.